I'm going to talk to you about hypertriglyceridemia. We're going to talk about the clinical consequences and approaches to management. So does hypertriglyceridemia correlate with increased risk for cardiovascular disease? And obviously the answer to that question is yes. Let's look at some of the data supporting this conclusion. Here we're looking at post hoc data from the Fibrate trial. And if you recall, Fibrate was performed in post-ACS patients. Everyone in this trial had a prior myocardial infarction. And they asked the question, for these patients, all of whom were on statin therapy, if you compare outcomes for patients whose triglycerides were above or below 200 milligrams per deciliter, what do you see? Well, the patients whose triglycerides were under 200 milligrams per deciliter, which I think is approximately 2.3 millimoles per liter, had a 40% lower risk of sustaining acute cardiovascular events during the follow-up period. That is a huge amount of residual risk. If you look at the MIRACLE study, which looked at 80 milligrams of Lipitor in patients who were post-ACS, you find a very strong gradient of rising risk as triglycerides increase on statin therapy. You'll notice that there is a strong relationship for rising risk for hard cardiovascular events, including mortality. In the DAL outcome study, in the panel on the right, you're looking at just under 16,000 patients. Everybody in this study was on a statin, and you'll notice that it doesn't take much in the rise of triglycerides to induce substantial elevations in risk for cardiovascular events. As we look at these quintiles going from less than 80 milligrams to greater than or equal to 175 milligrams per deciliter, there is clearly a stepwise increase in risk for cardiovascular events in patients who were status post and acute coronary syndrome. Now, this is brand new data out of the Framingham Offspring study. The assumption is, in most guidelines, that a triglyceride of over 150 or over 200 is abnormal. But what is startling here in the Framingham Offspring study is that risk begins escalating, not at 150, not at 200, but it begins escalating with a triglyceride of 70. And in fact, when triglycerides approach 81 milligrams per deciliter, you begin to see disturbances in lipoprotein physiology. You'll notice that the bulk of the elevation in risk associated with triglyceride levels occurs between approximately 75 and 200 milligrams per deciliter. Once the triglycerides go over 200, there's a plateauing effect. So the triglycerides don't have to be 200 or 300 in order to incur excess risk for acute cardiovascular events. The bulk of the action occurs between 75 and 200. When you compare patients who have triglycerides above 200 or less than 150, what do you see? Well, typically triglycerides less than 150 are considered normal around the world. But when you compare the two groups, what you find is that the risk for an acute cardiovascular event increases 35% in the patients with trigs over 200. Non-fatal MI increases 35% over approximately 3.3 years of follow-up. Stroke increases 27% over 3.3 years of follow-up, and the need for coronary revascularization via PTCA or CABG increases 51%. This is a level of risk that we can't leave on the table, which is why it's warranted that we further characterize the exact nature by which triglycerides increase risk for cardiovascular events and how best to attenuate this risk. So hypertriglyceridemia correlates with multiple alterations in lipoprotein physiology. Basically, when triglycerides increase, the waters of lipoprotein metabolism get very, very muddy. So what happens in the setting of hypertriglyceridemia? there's a wide range of physiologic disturbance. VLDL and chylomicron remnant levels increase, and remnants are simply incompletely digested chylomicrons secreted from the gut and VLDL secreted from the liver. They are the principal means by which triglycerides are transported in serum. Triglycerides, of course, cannot simply float in serum because they're hydrophobic, they're immiscible. They have to have a lipoprotein carrier to transport them from tissue to tissue. Apoprotein C3 increases. As LDL gets more enriched with apoprotein C3, in fact, it becomes far more atherogenic. High triglyceride levels correlate with very high levels of small dense LDL cholesterol, and smaller particles are believed to be more atherogenic because they're more prone to oxidation. They have a lower affinity for the LDL receptor and hence reduced clearance from the systemic circulation. And in fact, they tend to be more easily trapped by glycosaminoglycans in the subendothelial space of the arterial wall. HDL levels drop. You get procoagulatory changes. And why is this? Well, that's very interesting because actually hypertriglyceridemia correlates with an increase in endothelial cell dysfunction, and the balance between TPA and Pi1 is altered. It actually becomes procoagulatory, prothrombotic. And in fact, in the setting of hypertriglyceridemia, because it is so often accompanied by insulin resistance, you find that coagulation factors 2, 7, 9, and 10 also tend to be increased in serum. And then, of course, as triglycerides become severely elevated, there's augmented risk of pancreatitis because of resultant small vessel sludging of plasma, the induction of inflammatory storm within the pancreas, followed by autodigestion. So when I say that triglycerides muddy the water of lipoprotein physiology, what do I mean by that? Well, very specifically, let's take the example of a diabetic, someone who is insulin resistant. So visceral adipose tissue stores become resistant to the effects of insulin, and you no longer have a braking mechanism on hormone-sensitive lipase within adipocytes. The adipocyte becomes a constitutive source of free fatty acid release, and you veritably flood the portal circulation with free fatty acid, and the liver has to do something with this, and so it has a decision tree comprised of 4 points. Number 1, it can simply reassimilate the fatty acid into triglyceride, package it into VLDL, and secrete it back into the central circulation, in which case you're going to increase triglyceride levels. Number 2, some of this fatty acid can most certainly be oxidized as fuel within the mitochondrial matrix. Third, you can observe an activation of phosphoenol pyruvate carboxykinase, which will lead to an increase in glucose and glycogen production, exacerbating the hyperglycemia. Or fourth, the liver says, I can't cope with all this excess fatty acid, and triglyceride is deposited within the liver as hepatic steatosis. That, of course, worsens the liver's insulin resistance. So what happens as more and more VLDL is secreted into the central circulation? Well, in the setting of insulin resistance, lipoprotein lipase is inhibited. And lipoprotein lipase is the important lipolytic enzyme that hydrolyzes the triglyceride in the lipoprotein core to release free fatty acid that can be burned as fuel by systemic tissues. But the enzyme is inactivated in many cases, and you cannot allow for triglycerides to simply accumulate indefinitely. So there has to be a safety valve. And that safety valve is an enzyme called CETP, or cholesterol ester transfer protein. It's the job of CETP to remove the excess triglyceride from VLDL and VLDL remnants and exchange it for cholesterol into HDL and LDL particles. The problem is that this is a very expensive means by which to eliminate excess triglyceride. Why? Because now you're rendering the triglyceride-enriched LDL and HDL better substrates for lipolysis by hepatic lipase, and this leads to catabolism of HDL, a drop in HDL in serum, and importantly, a massive elevation in small dense LDL particles. This is the so-called atherogenic lipid triad, where there's high triglyceride, high VLDL remnants, accompanied by low HDL and large numbers of small dense LDL. As the LDL gets smaller, denser, more numerous, you're pounding the arterial wall. And this, of course, leads to accelerated atherogenesis. Is there genetic evidence that hypertriglyceridemia correlates with elevated risk for cardiovascular events? And the answer is yes. The enzyme I just told you about, lipoprotein lipase, has very complex regulation. Triglyceride metabolism is highly, highly regulated. Why? Because it's actually a more important substrate to drive the cell's energy needs than glucose. In myocardium, it's actually the preferred substrate over glucose. So how is lipoprotein lipase activity regulated? Well, you have cofactors like angiopoietin-like proteins 3 and 4, which are inhibitory. Angiopoietin-like protein 3 actually induces a dissociation of the 4 subunits of lipoprotein lipase because it breaks the disulfide linkages holding the cofactors of the enzyme together. Angiopoietin-like protein 4 is a direct inhibitor. Apoprotein C3, it's an inhibitor, induces allosteric hindrance so that the enzyme cannot interact with triglycerides within the lipoprotein core. Apoprotein A5 is an activator. Apoprotein C2 is an activator. So when we look at the genetics of this via Mendelian inheritance studies or genome-wide association studies, what do we see? Well, if you knock out the inhibitors of the enzyme like apoprotein C3 or angiopoietin-like proteins 3 and 4, consistently you see reduced serum triglycerides, reduced remnants, but you also observe substantial reductions in risk for coronary calcification, for heart events, for mortality. If ApoA5 experiences a gain-of-function polymorphism, again, triglycerides drop, risk decreases. And when you look at genome-wide association studies, in 2 different studies, 149 and 185 single nucleotide polymorphisms, all leading to elevations in serum triglycerides, all correlate with increased risk for future cardiovascular events. We know that genome-wide association studies and Mendelian inheritance studies inform the discussion about the role of specific risk factors in highly, highly sensitive and specific ways. This reproduces very nicely. Now, what's the role of remnants? It's big. So again, what is a remnant? It's an incompletely lipolyzed VLDL or chylomicron. If you recall, VLDL is converted to progressively smaller VLDLs as the triglyceride mass within the particle is reduced. It then becomes an IDL particle, and the IDL is converted to the end product of lipoprotein metabolism, which is LDL. Remnants are very, very nasty, and they accumulate in serum in patients with hypertriglyceridemia. Remnants are more easily oxidized than LDL, but in fact, remnant particles do not have to be oxidized in order to convert macrophages into scavenging macrophages that avidly take up lipoproteins in the subendothelial space. Remnants are found in atherosclerotic plaque, and studies since the 1960s confirm that remnants are actually important, which is why there was a very important influential editorial in Circulation way back in 1977, positing that atherosclerosis was in fact a postprandial disease because of elevated remnant lipoprotein levels in serum. So are remnants pro-inflammatory? The answer is, oh yeah. If you compare the impact of rising levels of remnants on CRP in the left-hand panel to rising levels of CRP in response to LDL, you'll notice that the remnant lipoproteins increase the expression of inflammatory mediators like CRP and IL-6 7-fold more than LDL. This is a big issue. And this is why patients with hypertriglyceridemia do in fact experience accelerated atherogenesis. So what has fibrate therapy taught us? Fibrate therapy are widely used throughout the world. Europe has tremendous experience with fibrates. Let's look. Here's a meta-analysis looking at the Helsinki Heart Study, the VA HIT study, the bezafibrate infarction prevention study, Field and Accord. And when you look at the patients with triglycerides over 200, HDL less than 40, there's a 35% relative risk reduction across the board. If you look at patients who are all comers, don't have high triglycerides, there's only a 7% not significant reduction in risk. Fibrates are PPAR alpha agonists. Their role is to reduce triglyceride levels in serum and increase HDL. Obviously, if someone has a specific kind of cancer, you target that cancer with specific drugs. You don't just give them any drug. Well, the same is true of patients who don't have hypertriglyceridemia. Why would you give them a drug that reduces triglycerides if they don't have high triglycerides? If someone has high triglycerides, you give them a drug that lowers triglycerides. It only makes sense. In the patients who have high triglycerides, fibrates work. Let's take a deeper dive into the Field study. Field was a negative study in terms of the primary composite endpoint, but the primary composite endpoint was only comprised of mortality and non-fatal MI. Did you know that had they included stroke, it would have been a positive study? All modern cardiovascular trials, at minimum, include mortality, non-fatal MI, non-fatal stroke. So what do we see? Oh, thank you very much. For the study as a whole, non-fatal MI was reduced by 24%, cardiovascular disease-related events 11%, revasc 21%, ACS 18%, and silent MI 20%. But if you look at the patients who had triglycerides over 200 or 2.3 millimoles per liter with an HDL less than 1 millimole per liter, what do you see? 27% relative risk reduction, statistically highly significant. Again, if you target the right patient, the drug works. There's no wonder in that. Okay, so in the Field study, the primary composite endpoint is negative because it's 11% statistically not significant. But if you look at high triglycerides, low HDL, it's 27%, p-value of 0.005. In the Accord lipid study, which also looked at diabetic patients, everyone's on statin background. Half the patients get fenofibrate, and we know that the study was negative. But among patients who had high triglycerides, low HDL, 31% relative risk reduction. But for those of us who treat diabetic patients, what's really important? Well, everything is. But microvascular disease is high on the list. And statins, ezetimibe, and PCSK9s don't address microangiopathy. What happens for retinopathy? In Field, using fenofibrate against placebo, all retinopathy reduced by 31% with early curve separation by about 6 months. That's a big deal. If you look at macular edema, reduced by 31%, significant at 6 months. Proliferative retinopathy, 30%, curve separation at a year. Any maculopathy, proliferative retinopathy, look at this, 36 and 38% relative risk reduction. Now, if a patient had no prior history of retinopathy, no prior history, fenofibrate reduced risk of developing retinopathy by 49%. What diabetic would say no to that? How about if they had a history of retinopathy? The benefit is less at 24%, but it's still significant. Now, how about if you look at a cohort? They used fenofibrate. Did they see a benefit in terms of proliferative retinopathy? Yes, reduced by 40%. So what's going on here? Well, obviously, in diabetics, we know that there is profound heightening of systemic inflammatory tone. And they develop retinopathy because there are derangements in the retinal brain barrier. What happens? The endothelium lining the retinal brain barrier expresses adhesion molecules, but it also gets sick. The pericytes comprising this delicate, lacy vasculature gets ill, gap junctions loosen, and it becomes permeable to the infiltration of inflammatory white cells. As we see here in the bottom panel, nuclear factor kappa B expression increases in diabetics, and nuclear factor kappa B is a nuclear transcription factor that regulates the expression of over 200 pro-inflammatory genes. You'll notice, moving farther to the right, diabetics given fenofibrate dramatically attenuate the nuclear factor kappa B expression intensity, as we see here in confocal imaging. Leukocytes per unit field in the retinal brain barrier decrease with fenofibrate. Permeability decreases. Retinopathy decreases. What happens to the pericytes comprising these delicate arterioles and capillaries? Well, what you find is that fenofibrate reduces pericyte apoptosis, and it improves gap junction function between these cells, helping to maintain integrity of the retinal brain barrier. Adhesion molecule expression decreases, and the intensity of inflammation and the expression of vascular endothelial growth factor decrease profoundly, as we see here. Fenofibrate dramatically reduces arteriolar expansion, proliferative retinopathy, because it even reduces the growth factors that regulate the expansion of the endothelial and pericyte cells. How about the risk of amputation? Reduced by 36%. Is that important to diabetics? Absolutely. Okay, but what's the breakout? You really see nice reductions of 46% in toes and feet. I'll take that. But major amputations above or below the knee not impacted. But toes and feet count. And ask any diabetic if they like the idea of having to lose a toe or a foot. Okay, how about when it comes to nephropathy? So patients who have stage 3 CKD and are diabetic, look at this, 32% relative risk reduction in the primary composite endpoint. This is an exploratory analysis, so it's post hoc, it's hypothesis generating only. Patients with better renal function did not experience statistically significant benefit, but for patients who had stage 3 CKD or worse, 32% relative risk reduction in the primary composite endpoint. Again, that's important. Okay, so obviously FIELD was probably the most positive negative cardiovascular trial in history. This is an incredible amount of benefit, and I don't think it should be neglected. Okay, how about omega-3 fish oils? Well, as we all know, looking at EPA-DHA combination therapies, we've had 7 meta-analyses since 2007, all showing that fish oils, when used as EPA-DHA combinations, do nothing for cardiovascular events. We've had a slew of studies. And you can look at any individual cardiovascular endpoint, they're all negative. So that's what makes REDUCE-IT unique. It used EPA or eicosapentaenoic acid monotherapy at 4 grams daily. Now, this is a study that I think took the world by storm. What were the key inclusion criteria? You had to be 45 years of age or older with established CVD, or you had to be 50 years of age or older with diabetes and at least one additional risk factor for CVD. Fasting triglycerides had to be between 150 and less than 500. However, let me tell you that the true range of triglycerides in this study was between 83 and 1401. They actually had 46 patients with triglycerides over 1,000, and a lot of patients with triglycerides over 500, which is why in the United States, the FDA gave them an indication independent of serum triglycerides. And this is because of the way that the randomization scheme worked. The washout period was somewhat complex. I'm not going to go through all that, but bottom line is there was a very broad range of triglyceride in this study. LDL had to be between 40 and 100 on statin therapy. And everybody in the trial is on statin therapy. Exclusion criteria included New York heart failure class 4, severe liver disease, history of pancreatitis or hypersensitivity to fish and or shellfish. The mean age was 64. Women were just under a third. And the study was performed all over the world. The bulk of patients were on moderate statin therapy at 62%. Another third were on high-dose statin therapy. If you look, 57.9% of patients were diabetic, and the baseline triglyceride was 216 with HDL 40, and LDL was already 74 with a median LDL of 65. Okay. CRP at baseline 2.2, and ApoB, if you're interested, was at 82 milligrams per deciliter. So what'd they see? You're looking at p-values that you've never seen before in a lipid prospective randomized study. There are 8 zeros in front of the 1. The primary composite endpoint was comprised of cardiovascular mortality, MI, stroke, coronary revascularization, unstable angina. You see substantive curve separation by a year. The absolute risk reduction was 4.8% with a relative risk reduction of 25% and a number needed to treat of 21. Now remember, everybody in this study is on a statin. LDL is already pretty low. And if you recall in the Jupiter trial, that was a placebo-controlled trial looking at rosuvastatin 20 versus nothing, and the NNT of Jupiter was 20. Here everybody's on a statin, and you've added EPA, and the NNT is 21. That's incredible. The secondary endpoint is CV death, MI, or stroke. 3.6% absolute risk reduction, 26.5% relative risk reduction, and an astonishing p-value. These are numbers we've never seen before. So how about when we look at subgroups? And the bottom line here is that there was no heterogeneity among the most important subgroups, which would include the primary and secondary prevention cohorts, whether you were a man or a woman, whether you lived in the US or lived outside the US, whether you were or were not diabetic, and benefit was independent of triglycerides, whether you looked at triglycerides above or below 200 or above or below 150. So then where was the benefit? Well, that's a good question. And people are going to be debating this for quite a long time because EPA does a lot of things. Probably one of the most important things that EPA does, it potentiates the production of a large family of molecules called protectins and resolvins. And these are complex derivatives of not just EPA, but also leukotrienes and prostaglandins, because EPA impacts leukotriene and prostaglandin metabolism. And resolvins can put the kibosh to inflammation, just shut it down. Protectins play a variety of roles and also can inhibit cellular apoptosis or programmed cell death. This is very complicated. It's a huge black box. We have a long way to go before we understand this. But the bottom line is, EPA worked. And for whatever reason in the history of EPA DHA trials, there's just something about the DHA that perhaps antagonizes the benefit of EPA or attenuates it enough so that you don't see positive studies. Alternatively, in those other studies, perhaps the fish oils were underdosed, but I don't think so, because even the recent strength trial, which looked at 4 grams again, was a futile study. It was shut down for futility. So let's look at some of the individual endpoints. Fatal or non-fatal MI, 31% reduction. Urgent or emergent revascularization, 35%. And for the first time in a combination lipid-lowering study, cardiovascular mortality was reduced in a statistically significant way. This was never shown with ezetimibe, has not been shown with the PCSK9 monoclonals, and has not been shown with fibrate therapy. This was the first agent when used on top of appropriately dosed statins to reduce cardiovascular mortality. Hospitalization for unstable angina reduced by 32%, fatal or non-fatal stroke 28%. Total mortality, trend for benefit did not hit significance, but what I will tell you is that when they looked at just the US population, all-cause mortality was reduced by 32%. For the group as a whole, for the cohort as a whole, sudden death was reduced by 53%. These are monster numbers. How about adverse events? Well, bottom line is there were some adverse events, which I'm going to get to in just a slide, that are very important. But for the cohort as a whole, in terms of treatment emergent adverse events, in terms of adverse events leading to study withdrawal, leading to death, no difference between groups. But there were a few that were important, of course. Number one, we know that EPA exerts antiplatelet effects, and that probably contributes to some of its efficacy for reducing cardiovascular event rates. Bleeding is slightly increased. If you look at GI bleeding, central nervous system bleeding, other bleeding, there's trends for a higher rate, but none of it hits statistical significance. And no one died from bleeding in the trial. Peripheral edema. There was a slight signal, 1.5% absolute risk difference, but there was no signal for heart failure. So is it serendipitous? I don't know. Atrial fibrillation, absolute risk increase of 1.4%, but if stroke was reduced by 27% and sudden death was reduced by 53%, I doubt whether EPA is arrhythmogenic. So I'm going to conclude. Hypertriglyceridemia is most certainly associated with insulin resistance and multiple genetic polymorphisms, as I've reviewed. Hypertriglyceridemia is a risk factor for both coronary and peripheral arterial atherosclerosis. Lifestyle modification is an important component of hypertriglyceridemia management. Fenofibrate therapy correlates with reductions in a wide range of macro and microvascular endpoints, as I showed you. And these are extremely important to keep in mind, especially with the microangiopathy. There's profound benefit in terms of reducing risk of retinopathy, amputation, and for patients with CKD, there appears to be particular benefit. Combination EPA-DHA therapy has not demonstrated cardiovascular benefit to date, but the REDUCE-IT trial shows that EPA monotherapy, when used in combination with a statin, even when LDL levels are at target, among patients with hypertriglyceridemia, provided very substantive and meaningful reductions in hard endpoints across the board. And with that, Dr. Kovic, I'm going to stop. Thank you so much.
Peter, you said you're not very interested in atrial fibrillation. And there was also atrial flutter, by the way, was also increased. But the idea with what I have as an anxiety in there is two things. First, in general, fish oils are antiarrhythmic. So why do we see that in this particular example? And secondly, what I'm worried about is that long term, if this is a membrane effect with a big dose effect, so that you replace the membrane and you change the membrane characteristics, that actually if you stay on this treatment for more years, then the atrial fibrillation will not be just 1 point something percent, but will actually start rising. So I don't know if that is speculation, but I think it should be looked at a little bit more carefully. And I see that a lot of presentations, it's passed over. It's not actually elaborated.
Well, actually, Dimitri, it doesn't cause me much anxiety. I'm sorry it causes you anxiety. I think what reassures me here is that you're not seeing a signal for stroke, and we know unequivocally that atrial fibrillation correlates with a signal for stroke. And we also know that sudden death was reduced by 53%. So if sudden death is reduced by 53%, we know that most certainly it's not arrhythmogenic, at least at the level of the ventricular electrical system. And I think a lot of EPs have looked at this issue, and I think most people are concluding that it's a spurious finding. Now, I think that when we talk about loading membranes with EPA, there's certainly going to be a limit. You can't infinitely load because cell membranes have only a certain number of slots they can accommodate a long chain polyunsaturated fatty acid like EPA. The membrane gets saturated as well, and that probably happens pretty quickly just based on the biophysics of it. And some of it will be consumed, some of it will be taken up. There'll be a steady state that's achieved because the EPA can be burned through beta oxidation, the mitochondrial matrix. So I don't think there's any suggestion that there's some toxic level that builds up over time. So your question is asked by a lot of people. It's, of course, a very important one. But I think what reassures people is that the sudden death and the stroke signals are so strong despite this 1.4% increase in atrial fibrillation.
You're absolutely right. And that's why I think it may well be a spurious result. It may just be accidental. We've seen this in other trials, a statin trial showing increased cancer and things like that. But it's not confirmed by more extensive trials. But going back, if you have 1.4% increase in AF over a certain time period, they didn't get the AF from day one. So over a small period, would you see a stroke difference? Because it's only 1.4, and 1.4, all of them will not get a stroke. And not only that, they won't get a stroke within the time span, and we don't know when they developed it. If they developed it towards, say, the bottom half of the trial, then there is no time to get yet your stroke. So I still remain cautious and skeptical, but on balance, I agree with you. I think it's probably a spurious trial finding, and I would like to see a little bit more to confirm that, for example, another trial with this product showing no AF, then I would be totally convinced.
Okay, my only response to that, Dimitri, and you know I love talking with you. We talk a lot. But bottom line is, when you're looking at a trial that for the first time using some therapy over and above a statin, you reduce cardiovascular mortality by 20%, sudden death by 53%, MI, all MI by 31%, stroke over and above statin by 27%, why wouldn't you use that? Yes. Yes.
Cristian Sarafinciano, Bucharest. Thank you, Professor Toth, for your outstanding lecture. But I think when we are talking about, I'm a specialist in metabolic diseases. When we are talking about triglycerides, we have to talk separately about basal levels and postprandial levels of triglycerides, because there are huge differences in their metabolic effects I think in field study and in accord lipid study, they are talking about basal levels of triglycerides, meaning fasting levels of triglycerides. But the postprandial effects of triglyceride, including VLDL production and cholesterol inclusion in VLDL, they must have some macrovascular effects. What do you think about it?
I'm not sure I understood your question.
No, because in the field and also in accord lipid studies, they found positive relationship only with microvascular disease. But I think also about their postprandial high levels of triglycerides, do you think are there any macrovascular involvement of triglycerides?
Oh yeah, absolutely. So yes, that's a very, very poignant question, because all these studies are done with fasting triglycerides, but obviously people are basically postprandial all the time, except when they're sleeping, and diabetics can have a profound potentiation of their hypertriglyceridemia by virtue of the insulin resistance. So this is a crucial question, but I think some studies have really looked at this in a postprandial setting, not major clinical trials. But we know that postprandial hypertriglyceridemia exerts a profound dampening effect on vasodilatory capacity, endothelial cell dysfunction. It potentiates inflammation, no question, and remnants play a very important role in that. And as I showed from the Copenhagen heart study, remnants are 7-fold more pro-inflammatory than our LDLs. And so your point is extremely well taken. Postprandial hypertriglyceridemia is highly injurious, not only to the micro, but also to the macrovasculature. And the remnants that we see in patients with diabetes most certainly play a very important role in inducing pathophysiologic changes in the retinal brain barrier within the glomerulus, I'm quite sure, and then also the small vessels of the peripheral vasculature. But these are issues that obviously require a tremendous amount of more study.
In the light of this, I think more speculations about the postprandial effects of triglycerides. Why we don't recommend to our patients fibrates for prevention of such macrovascular effects?
Well, I do. I use a lot of fenofibrate. And in diabetic patients, I use fenofibrate routinely if they have any history of retinopathy. I use it routinely in patients who have hypertriglyceridemia and CKD. I have no problem with that at all, because in fact, I think it's pretty well established that fenofibrate does not adversely impact renal function based on very carefully done inulin studies. In fact, it preserves glomerular function. In the field study, after 12 years of follow-up, when they looked at GFRs, in fact, the people randomized to fenofibrate had a substantially lower rate of decay in GFR than patients randomized to placebo. And obviously, it protects against amputation. But there were also benefits in the patients with high triglycerides for MI and stroke. It's very clear. Yeah, of course.
In light, Professor Toth, in light of the very interesting slide showing that there is an effect even below 150. In fact, the highest slope was below 150. Coupled with the fact that you've shown that there are very important effects. So could you then argue from here as an inference that such treatments should be the new aspirin. They should, all patients, in fact, with any vascular disease should receive them regardless of the triglyceride level.
You mean the EPA?
Yeah, because you...
Yeah, I think...
I mean, why
Yeah.
should we wait above a certain level if
Yeah.
you have that slide with the...
The FDA gave the approval in the U.S. for EPA for any triglyceride over 150, anything over 150, with no upper limit. And that was because they actually had 46 patients with trigs over 1,000. And so if you've got patients with even mild hypertriglyceridemia at 150, and they are diabetic and have at least one other risk factor, or they're in the secondary prevention setting, then certainly EPA is indicated.
even below 150.
Yes, I would have to say that the data are there for above 135, yes.
Any other questions from the floor? Alte întrebări? N-am primit niciuna pe mail.
Did you have a question?
Here we are diabetologists.
Yes.
And we don't use very much fibrates.
Yeah.
Except for the very high values, over 800, let's say. So because in diabetes, triglycerides are very sensitive to diet.
Yes.
And as you put a patient on diet, they'll cut down, they'll go down the level of triglyceride. So, and since the statin is quasi-mandatory, I don't see the utility of combining statins with fibrates because it's a little bit less well tolerated, you know. So we prefer to start with the statin and to see how the triglycerides will evaluate, and only after that, if there are some other problems. But I wanted to ask you, why, what would you prefer between, because I see you are an advocate of fibrates. What do you prefer between fibrates and omega-3 acids?
I'm an advocate of treating high triglycerides.
With what?
Well,
Mainly.
It depends on the setting. So if I had a diabetic who had microangiopathy, my choice there would be pretty clear because the benefit with fenofibrate for reducing proliferative retinopathy, for attenuating rate of renal decompensation, for reducing risk of amputation, that's very clear. And those are all very important endpoints for diabetic patients. If the patient was diabetic, didn't have evidence of any microangiopathy, but had a very substantial risk from the triglycerides, I might use the EPA first. But as you know, there are diabetics who have severe hypertriglyceridemia, and they would require both drugs on top of the statin in order to help them normalize their triglycerides. It just depends on the clinical scenario. My only caution to people is not to forget about the microvascular benefit of fenofibrate therapy in diabetics.
Yes, and unfortunately we don't use much in Romania. Just I don't know fibrates for retinopathy.
Thank you very much.
I know in Australia is an indication, and they
Yes.
are covered fibrates for retinopathy, but,
Yes.
but not here.
Yeah.
And is the U.S. also?
In the U.S., they were not approved for microangiopathy.
You see?
Yeah, but that doesn't mean that I can't use them for microangiopathy.
Off-label, yeah.
Yeah.